So just like lutetium, terbium is also given in fractions, so it's given in cycles. Typically a person would require about 4 to 6 cycles of terbium-161 labeled either PSMA or dotatate, whatever is the tumor in question. And these therapies are usually given at intervals of about 8 to 12 weeks, so depending on the disease that you're treating. So the supply of terbium is fairly stable as of now. It comes from the Netherlands, from a company called Terbium, which is the largest producer of terbium, which is used for medical uses across the world. We do get terbium about twice in a month, and so usually patient scheduling is not a problem. Has a gamma ray energy which allows us to do an image-based dosimetry, and so typically the patient would be scanned for a post-administration dosimetry scan once the same day, once the next day, and once after 3 to 4 days. So these scans help us in deciding how much dose has actually been administered to the tumor, how much dose has been administered to the kidneys, to the bone marrow, and these may help us in deciding how many cycles we can safely deliver to the patient, whether there is any risk of dose-related toxicity to the end organs like the kidneys or the bone marrow, and whether we are able to actually administer adequate dose to the tumor cells to cause their cell death. So people ask me that patients who don't respond to lutetium, will they respond to terbium? I don't know. We don't have any data which actually says or looks at patients who have not responded to lutetium and whether they have a enhanced response to terbium. The theoretical benefit is there. So there is a possibility that patients who did not respond to lutetium or who had an inadequate response to lutetium or had a response to lutetium and are now progressing, they may have an advantage on giving terbium instead of lutetium, but we still don't have the data. The data that we have, and which comes from preclinical studies, is that recurrence rates with terbium will probably be much lower than lutetium because of the ability of terbium to kill the single cells, which are actually the residual cells which are responsible for recurrences. So it may be a terbium versus lutetium as a first line, rather than using terbium in patients who fail lutetium, which is going to be the protocol in the future. There is a large study which is happening in Australia called the Violet study, and that is being done by Professor Michael Hoffman and his team, and they are doing a head-to-head comparison between terbium and lutetium. And their initial results are very encouraging, and their initial results are showing that terbium definitely has a much better efficacy as compared to lutetium. So who knows, maybe in the future terbium is going to replace lutetium as a first-line therapy. So the advantage of terbium is that with each unit molecule or each unit millicurie of terbium, we are able to deliver almost 40% more radiation dose to the tumor. So we know that every unit or every millicurie of a radioisotope will have some degree of toxicity or potential toxicity, whether it is renal toxicity, whether it is bone marrow toxicity. Now, if we are able to deliver the same amount of radiation dose, a concentrated radiation dose to the tumor with a 40% reduced overall radioisotope that we are injecting into the patient, there is a huge scope for reduced toxicity with terbium as compared to lutetium. So we know that lutetium itself, the toxicity is less. With terbium, we expect it to be even lower.